Thank you, Amy, Dr. Uh, thank you, Dr. Amy, for the introduction. Glad to be here. Actually, Amy connected us with this group with Josh and I, so this is our first time. Excited to be here. So yeah, Josh, can we move on to the next slide, please? So today I'll focus on just on a background on generalizable impact, loss of generalizable impact, and then we talk about existing frameworks that try to capture generalizable impact at different stages. What are the gaps? And then Josh will walk us through tools that we revised, but also a new tool that is in the process of iteration for us to use it as a planning and reporting tool. And then at the end, what does this all mean? So Russ kind of will help us kind of close it up with the purpose of all of this work. Josh, yeah. So these are just some discussion questions. I'm not going to read it now, but we leave it for you just to think about, regurgitate as we go through the slides. And, we'll come back to this at the end, but we'll leave this somewhere in the chat. So we want to, just, before we start, whatever is presented here, it's that of the authors. It's not that of the funders, such as the National Institute of Health, ARSA, and others here, including the Anschutz Accelerated Initiative, which funded each of our work here. So starting with the generalizable impact, here, in terms of the way we define it, is a balance between this internal and external validity. And this reflects both on the ability to replicate findings within a study and the potential to apply those findings to the broader target population. So the three buckets here, the key factors that we consider are important for that influence generalizable impact are participation, meaning the rate of participation, the settings, the participants, and then the representativeness, meaning the settings, how well diverse or like representation from the different geography and the types of health system that are represented within this trial, but as well as the effectiveness, the level of intensity, as well as rate of engagement during implementation. How are all these kind of these different stages combined or individually? How do they influence generalizable impact? So if you go to the next slide, health outcome researchers hope to make population level impacts. But often, these aspirations fall short. And relating it with the previous slide about these three factors, whenever there is suboptimal participation at multiple levels, that combined with or individually with limited representativeness at all levels, and as well as reduced effectiveness, poor fidelity, lower program intensity, and insufficient tailoring. All of these combined or individually result in loss of desired generalizable impact of an intervention during and after the study. So what we try to do in this study is our study aims to provide, what are current existing studies, briefly, that report or try to capture about participation, representativeness, and effectiveness that leads to generalizable impact. How are they approaching this with the use of frameworks and tools? But as well as, part of this is not just to tell you what the gaps are or what the limitations are, but also to provide guidance to identify and mitigate drop-offs and generalizable impact. And part of this guidance also includes some tools that that have been looked at previously by Russ, Amy, and some others, building on those ongoing works, but also a new tool that we're going to share with you today that kind of comprehensively looks at the multi-level as well as this dynamic longitudinal planning and reporting tool that you can actually use to anticipate, plan, mitigate, as well as report generalizable impacts. And then Josh also will provide some really cool demonstration at the end. So our approach to exploring and addressing the problem, so it has these two overarching groups. So first, just trying to understand the lay of the land. We did a brief literature scan uh, to understand the methods, frameworks, examining uh, generalizable impacts at different phases. So rather than at one point in time, starting with planning, during implementation, evaluation, as well as reporting, transparent reporting. At these stages, how are some studies have described the challenges as well as the ways they addressed some of these challenges. That in a way could also help us to think about, how the frameworks and the tools that we're going to be discussing about today, how they can address some of these gaps that we've identified or learned uh, in the literature scan. So the next bucket of approach we used is, given that this is the REAIM consortium working group. So it is embedded, like the way we're approaching this is embedded within the REAIM framework. Meaning, so we try to map some of these cascade effects using the REAIM cascade to see how drop-off influences effectiveness as well as sustainability as you go through the different steps, and how you can imagine participation, representativeness as well as effectiveness within this frameworks. But also, we're going to review, we reviewed and revised existing tools such as the REAIM framework as well as the expanded consort that I'll shortly talk about briefly. And then we conceptualized and conducted initial user testing of a new tool. So what do we learn from the literature scan? It's a brief exercise that we did, but when we look at it, I think I might have heard Russ a couple of times in this REAIM group. I watched some of the videos. This idea of iterative and dynamic, like longitudinal capture, as well as this multi-level. So the way we try to learn about this is like trying to see, okay, in the planning phase, what are some, individual as well as system level challenges that may influence generalizable impact. So in the planning phase, thinking about, the eligibility criteria may be restrictive, may have, some kind of cultural and language barriers, but as well as in the same stage about recruitment, being able to, at the individual level, some distressed and logistical constraint for certain participants, certain groups to take part in these in trials, in trials in the initial stage. But as well as in the implementation phase, thinking about how do you retain, how do you motivate for folks to continue to engage. And sometimes some structural barriers include physical proximity, as well as costs to continued engagement, and other structural and social determinant of health barriers that might influence retention. And in terms of evaluation, the way they reported, often, do they include, power dynamics that shape participation retention? And, what we learn is like, trust and access influence those. But about one key thing here is about this transparent reporting. Often we do see participant loss are consistently documented and they're reported. For example, in the consorts diagram for trials, but there's limited emphasis on preventing these losses over time. And this is saying, as part of your planning, or even as you go through the implementation, how do you actually mitigate some of these losses? So there are some really useful frameworks that we found and we learned about, but also I think from Russ's and Amy's previous works that we kind of looked in depth just to learn about their application for such questions that we have. So I'm not going to go through in detail. I think you all can probably go through them, but the idea that some of them, they look at pragmatism, they look at, how pragmatic your research is, but also when you prioritize, when and how you should prioritize generalizable impact, but also thinking about representative measures using re-aim, and as well as expanded consorts. How you can think about this, the influence of this multiple setting, not just the study, but where you sample, where you source, but as well as in the last stage of your sustaining, where are you sustaining it for whom? So what remains to be done is the lack of interactive tools to anticipate, justify, or guide design decisions, but also limited attention to cumulative drop-offs across socio-ecological levels and implementation phases exist. And shift from primary focus, reporting losses, to proactive loss mitigation and prevention are something that is limited as well. So I think some of you may have seen this re-aim cascade. I'm not going to go too deep about this, but the idea here, thinking about from the adoption stage, this is, I think, and Monica, Russ, and Meredith Worth kind of put this forward previously. But the idea that if sites who you planned expected, if they did not adopt 100%, let's say if there's 20% drop-offs, the next cascade, which is the implementation among those who adopted, would also be influenced in terms of only of that 80%. If there's a 20% drop-off that actually implemented with quality, with fidelity, and as well as continued engagement, that would also influence who you reach as part of those that actually implemented with quality. And just like that, it goes this cascade effect, goes down to the effectiveness is influenced as well as the maintenance. So this idea of the re-aim cascade is not only you can apply it at the end of your study, but you can also do this from planning, during implementation, as well as at the end at multiple levels to see and try to apply, mitigate some of the drop-offs that you see at these different stages. So some questions that you can ask yourself to address some of these drop-offs and to mitigate and also plan is, especially starting with adoption, is to think about, what, your choice of the setting, the engagement, how are you engaging your potential population who would, benefit from your intervention. And, there are some considerations, Josh, if you can move to, yeah, so there are some considerations you can make by, for example, engaging potential partners early with scope and resources rather than in the middle or after you design your study, but also thinking about, site flexibility, integrating into also in existing frameworks. So to enhance your adoption for different level of settings. Can we go to the next one? And in the implementation, how complex is it for your participant and for your setting? And can you actually make adaptations to the intervention or for your intervention while maintaining the core function of your intervention, but then making some tailoring on that the forms of the intervention to fit that specific context? And thinking about how can we address barriers about participant engagement? Can you also include some form of strategies to enhance and improve up to motivation, engagement of certain participant who might drop off? And some consideration is define the core function of your intervention that you will not be able to modify, but then what are the forms you can actually modify to fit the context? And reach, with reach, although this is an outcome, but we also can think about this as part of planning. How can we make our recruitment strategies, our eligibility criteria in a way that is not too restrictive to exclude certain folks, but making it more of an inclusion criteria that try to capture and involve as much diverse population as possible from different settings. And some consideration is, piloting and refining your recruitment strategies, but also thinking about, as you're planning, as your recruitment and as well as eligibility criteria, if it's too restrictive, what changes can you make in a way that doesn't affect your overall outcome, but also it's uh, within your the possibility of your resources. Uh, so in terms of outcomes, so here effectiveness, I think there's implementation effectiveness, but also there's clinical effectiveness where it's very standard. But here, we're thinking, you know, when you look at your outcomes, are there some differences among different populations? I mean, we can use the word equity nowadays with NIH, I think, but is there difference? Are there differences by subgroups? Can you look at inequitable outcomes across different groups? And thinking about what are the unintended outcomes that you didn't plan for, and something that you can account for later. So the considerations. Josh, next. And the consideration to make here is like, monitoring outcomes over time, but also evaluating acceptability, feasibility, cost in a way who's it acceptable for, who is it feasible for, and for what setting. And thinking about these outcomes, not just only reporting acceptable, I think the usual, okay, we use this framework, this is the outcome, but also taking it one step further for whom and for what settings. And with maintenance, this is where, for the sustainment, is it for individual, group, but also have you thought about engaging the community or the population where you want to sustain this or scale up, or I don't want to use the word scale up, but the sustain is, have you engaged them? Have you found a way to say, okay, what resources do you need to sustain this? And, making sure it reaches the population you intended to reach. So this is where I think you participate, you engage community members throughout your process and report sustainability with intent and capacity. So being transparent. Uh, yeah. So I think I'll pass it on to Josh to talk about the cool stuff, not the conceptual, but the tools. But here you go, Josh.
So I'm just going to hit a pause. I'm not able to directly see the chat. I just wanted to see if there were any big burning clarifying questions kind of before we move into the demo part at this point. Ever saying?
Nope, I'm not seeing any, Josh. So.
Okay, perfect. So I'm excited. So again, tying all the things that we've put together here conceptually, thinking about generalizable impact, one of the goals that we really have and that we had in setting out with this work is really trying to provide some practical and useful tools to be able to think about how do we plan for, monitor, and report on issues around participation, effectiveness, representativeness, and generalizable impact. I'll be presenting 3 different tools today. They're all a little bit different, all with slightly different purposes. The one caveat that I just want to make is that intent by design and through intention is that each tool is not necessarily something that is universal across all studies. So we really want these to be able to be thinking about can they be tailored or useful for specific projects. So there may be certain things that might be more useful for, say, pilot studies that are a little bit easier, less onerous, or less time intensive versus a larger type 1 or type 2 randomized clinical trial. So the first tool that I'll be sharing today that we put together is built off of the re-aim cascade that we are sharing and thinking about how do we track a lot of the track and plan for a lot of the challenges that may come at these different project stages across re-aim. And again, organized in this kind of slightly rearranged kind of ARM, so adoption, implementation, reach, effectiveness, and maintenance. So I'm actually going to stop sharing the slide for just a second. And then I'm going to actually share my desktop so I can actually pull up what this looks like. So this is a Word document that's fillable for individuals. So again, here in the leftmost column, we have the research or the re-aim domains that we're looking at. So adoption, implementation, reach, effectiveness, and maintenance. And then have tried to identify some very specific, kind of call out some very specific challenges that can go on at each one of these stages. So, for example, with adoption, thinking about the challenge of how do we ensure that there's a diverse set of sites that are participating, for example. And then within each one of the re-aim domains, trying to address these specific challenges, really naming them out, and then providing essentially a worksheet to be able to go through proactively and thinking about what are some of the actions that we may take during the planning stage to really try and address some of these issues. We have also set it up so that in addition to just planning, that there is during the actual study implementation, that you can actually track and think about, well, what were the things that we are doing or the things that we have done to try and address some of these things. So having, again, this kind of longitudinal component here, and then an additional column for notes. So this is the re-aim cascade tracking worksheet. And I will come back to, after I've presented all three tools, just about access to these tools and kind of how we're distributing it. So for the second tool, so this is work that builds off of a work that was done by Russ, Amy, and Dr. Brownson, published originally back in 2018, and is essentially looking at, we referenced this earlier, is this idea of the expanded consort. So I'm just going to run through real quick, just kind of as a reminder to everybody. So this is just to kind of see the evolution of how we got here. So I think most folks on the call, maybe not all, may be familiar with the consort flow diagram, something that is often required as part of reporting of clinical trials, that has a large focus on thinking about what participants may we have lost over time or didn't necessarily analyze. Though there are a couple components that could be applicable to external validity, a lot of the focus is really here on internal validity and replication. So the goal of the original expanded consort that was published back in 2018, if we pull up here, is starting to address some more issues that are very important specifically to external validity and thinking about generalizability and some of these factors that we're talking about, who's participating, how representative are these different settings that we're engaging with. So what this does is it expands onto thinking about, okay, even when we're going into the study, what are the settings that are eligible to be participating or excluded, or participate settings that we invite to participate or settings that decline? And then thinking about this at the staff level, and then again, thinking about kind of the original consort is kind of down here at the participant level, but then also thinking down here at the setting level about some issues around sustainment. And then providing some information as we're going through here about thinking about what are some of the key differences that we're doing across. So at the level of settings that might be eligible or excluded, or settings that are participating or not participating, and actually providing some key differences there. What the second version is, it takes this and really tries to highlight at an even higher level, and I'm going to zoom in on this and expand it a little bit, is really thinking about this at some increased socioecologic levels. So before we had thinking about different settings, but breaking that up even a little bit more about thinking about how might we be engaging or thinking about the specific healthcare systems that we're going into, what clinics within those healthcare systems, thinking about clinicians and staff, which was included in the original version, thinking about participants. And then the other component that we have tried to build here into the second version is also thinking about, okay, we are delivering this intervention, a control arm and a treatment or intervention arm, but thinking about some of these components that may actually impact effectiveness. So thinking about, well, what percent of individuals actually receive the intervention with fidelity, and then the comparator with fidelity. How much do we feel like participants were sufficiently engaged within the study or treatment plan or intervention? And then addressing some of these issues around loss to follow-up. And again, so just expanding out on some of these other components. And again, The idea being that for each one of these steps and each one of these levels, that we're really trying to think about what may be the key differences that may exist between these different conditions, between these different arms, that may be important for us to be thinking about. The expanded consort is meant to be more retroactive. So this is really meant for more in the reporting and evaluation phases after study completion, as opposed to the re-aim tracking cascade, which it was a little bit more with the planning during and even can be used somewhat after study implementation. So that is the expanded consort. So again, building on previous work that had already been done. And then the last tool is one that we've conceptualized as part of this work of really trying to think and I would describe this one as the one where we're really kind of getting into the granular level of detail and really thinking about impact and how we can potentially make this useful. So haven't spelled this out, but it's the loss of generalizable impact calculator or logic. That's for planning or reporting participation, representativeness, and effectiveness. That's a huge mouthful, so we're just calling it logic prepare, which is also kind of long, but we felt like it really encapsulated the pieces that we're doing. This is intended, as far as timing goes, we have two separate versions. It's an Excel spreadsheet. One of which is meant for before study implementation, more directed towards planning, and then one that is meant for after study implementation and meant more for reporting. So I will share what those look like now. So this first spreadsheet, this is an example of the planning spreadsheet that we have. So it's broken down into several tabs that we have here. We have an initial tip sheet here in the first tip about kind of just to be able to help guide users as you're going through. And then we have these 5 different tabs. So one that's focused on settings plus population procedures, retention during the study across different time points, engagement and fidelity, questions around effectiveness, and then a last one, which we've marked as optional for now, is a sustainment tab. Within each one of these tabs, there are 2 components. So the component here on the left, which you'll see in the gold colored boxes, we would describe as more of a worksheet. So this is really meant to be a worksheet that allows for critical reflection on different levels or different factors that are impacting participation, representativeness, or effectiveness as you're going through these tabs. So for example, here, basically defining, so this is the setting and population procedure tab. So actually defining what a setting may be at these different levels, going all the way from the national level, if we're talking about a big multi-site or international trial, all the way down to enrolled participants or goal for enrolled participants in the study. And the output here is really meant to be, again, trying to critically think about what is our rationale for the choice of a given setting that we're working on, or our rationale for the total number of enrolled participants that we may be using. And then really trying to think about who might be lost or omitted at each one of these steps, and then why they might be lost. So again, this is really meant to be a critical reflection tool here in what you're seeing in the gold boxes. The second part of the calculator, where the calculator name comes from in this tool, is that in these aqua or blue colored boxes that we have here, is it actually lets you populate in numbers for these different levels, and giving some description on guiding what you will input at each one of these stages. And eventually what happens, and I'll show kind of what a completed version of this looks like, is it'll eventually show what the drop-offs and impact look like at each one of these levels. And then at the end of each tab, you can just hit next tab and it'll go to the next one. And again, this is where we have multiple different tabs again with this kind of critical reflection worksheet and then this calculator component here. thinking about these different levels here. I will just briefly show. So again, this is the reporting. This is a version of the reporting worksheet. The one I just shared is the planning worksheet. There's not that much difference except for a lot of it. We've changed the tense, the verb tense that we're using a lot of the. So overall, the structure of it is pretty much the same, but again, is focused on retroactive reporting and thinking about these different levels. But again, the same thing where we have this critical reflection worksheet plus a chance to actually input numbers specific to the study. So I'll demonstrate really quickly what this looks like when it's actually filled out. So again, this is just one tab that we've filled out here. And again, this is a kind of a mock case example that is loosely, very, very loosely based on some existing work. But again, thinking about as you're going through with a particular trial, thinking about the country that the study may be taking place within the United States, the state may be Colorado, and then specifically focusing on rural and urban counties, thinking about the health systems that may be participating in a given trial. So I've given a couple of examples here, providing some description of the different sites within those systems as far as who would be participating in the study, the clinicians that would be involved. And then what it's really meant to do again, and as I want to emphasize, right, this tool, again, with it being so comprehensive, again, really want it, doesn't necessarily mean that you need to fill in every single one of these levels. Especially as a fellow doing largely a lot of pilot work right now, I would not want to be filling in and providing justifications at the national level. So again, there's a bit of kind of where it is applicable to your study, and really emphasizing that. So again, providing a rationale for why we're choosing these different settings here, and then why we might be choosing within the population that we're trying to recruit and enroll, and the reasons for that. And then providing some reasons about who specifically might be lost or omitted at each one of these different levels and why they might be lost. And then what we do with the calculator portion, is actually able to input numbers and trying to provide some guidance here about what the numbers are specifically referencing. So again, thinking about what might be the total number of people that are served within a given system, the total number of people that may be served by the sites that are involved in the study. And then just, again, in the planning phase, a lot of these may be estimates, but just as we're going down, and then down to the level of the trial arms, what we have as the final output is this graph that I referenced earlier, where we're able to see as we're going down each one of these stages is seeing where potentially there's people that could be potentially eligible that we could be engaging with that are not necessarily being included, and seeing where some of that drop off here, specifically in participation, may be. So again, with kind of this output where it is. I haven't filled it in for these other tabs. Again, so this is just an example, but the slide deck that we send out with a PDF will have a screenshot of kind of what this looks like at the very end of the slide deck. So those are the three tools. I'm going to stop sharing and get back into the presentation. Slideshow from current slide. So want to emphasize that we are looking for additional user feedback on these tools. Again, our goal is to really make sure that these tools and these resources that we're trying to provide with impact are useful, the sort of thing that isn't just going to gather dust on a shelf, but really has practical implications for your work. We've provided a QR code down here at the bottom, which I can leave up for, we can come back to during the Q&A if folks want. And again, this will go to a survey link where you can request copies of the Expanded Consort 2.0 as a PDF. And then the re-aim cascade is that Microsoft Word worksheet with an option and opt-in to participate in a user feedback survey just to provide feedback on how it might be able to be improved. The last tool, the Logic Prepare Calculator, again, is a very early kind of prototype that we're working with. We've done some very early kind of initial user testing, but we are looking to do a bit more expanded user testing and continue to iteratively improve it. We are planning on trying to schedule some virtual Think Aloud sessions, actually going through the tool in May and June 2026, so coming up in the next couple months. So at this link, if you would be interested or willing to be contacted to participate in some of those Think Aloud sessions, there's a sign up there. And then additionally later, after we get past some of this additional early user testing, there's also an option if it's like, Think Aloud sounds like a little bit too much, but I'd be willing to receive a copy later and fill out a survey. We'll also have that option available for folks as well. So again, always takes a village to put together a lot of this work. So want to make sure that we're thanking Brian Ford, who has really helped with putting together this presentation, both here and elsewhere, and helping assist with a lot of these tools. All the members of the Accords Primary Care Research Fellowship. Want to thank the National Working Group on REAIM for inviting us to talk today. We have an abstract that's been accepted to present at CopperCon here at Anschutz in May, and then the manuscript for this work is currently under review in JCTS. So with that, kind of segueing into the discussion, I'm going to hand it over to Russ to take us home.
Thanks, John. I'll try to be uncharacteristically brief here because I know I'm standing between you and a fun discussion while you probably turned in. But I would like to just reflect a little bit on what we've done and where we're going there. First, though, I just really like to recognize Josh and Ermyas. They've really led much of this work, and especially the hard work actually designing the tools and the things there. And also a shout out to Josh for being brave enough to go back and forth and share his screens and do the live demo. I would have never been brave enough to do that, and he did it without a glitch. I will note that we've had a positive on the paper containing the write-up on these that Josh mentioned. We had a pretty positive and amazingly rapid review on that. So we're resubmitting that now, and if people would like to get a copy of that once it's been accepted, we'll be glad to provide that as well. Well, in terms of reflection on this, just one quick summary comment, and then I'll touch base on most of these points, and then we'll open it up for discussion. But reflecting back, I think a key need was that there were some, we feel, helpful tools for different stages of what we're doing to transparently report on things. Whether you want to use REAIM or some other framework, there are some great ones for planning. Like I really like, I'm a fan of the Precis tool. Before we'd published the expanded consort that Josh talked about, I'll have to say, parenthetically, that one's had a lot less uptake than we'd hoped for, and we're still trying to figure out exactly why. And then there's some other things in between, but we weren't aware of anything that integrates across the notion of planning and initially estimating, if you will, what can go wrong, then tracking during what's going on, guiding. One thing we haven't maybe emphasized enough, I really hope these can be used to guide adaptations. So you don't, not only do your best job at estimating, then you're tracking it, but when things go wrong, you can kind of adapt and then record that, and then finally for recording. So just quickly, a couple things about most of these bullet points there. I think proactive is the key point here, that we hope these can be used that way in terms of just working with your partners, your implementation partners, to anticipate what the issues are. Second, to look into some of the reasons why, the challenges that might be there. And one of the other things we tried to do here, unlike A lot of our previous work in REAIM, which I think has focused predominantly on the issues of reach and representativeness or external validity. We do feel internal validity is very important, and there is the E in REAIM there, but we've tried to more explicitly include both internal and external validity here. So we look at things that can impact effectiveness too, like tailoring and fidelity and ongoing engagement there. Just a couple other points, top right there. Uh, we think that the transparency is really critical. I'll mention that again in a second. But we don't expect any given study to excel or like hit a home run on all these, I don't know, 20 different steps or something that you could do. Some of them may not even be relevant to your studies, but the notion is by thinking about it, in particular, which are important to you and your partners there to do that. We do hope that the bottom line, this can help both increase the speed and the impact of translation into real world practice to address what David Chambers and others call this voltage drop, or we've used the term drop off. And the last thing I will just say, it's one of my current soapboxes here, is I think that the transparent reporting is so critical and maybe fessing up that all of us, maybe we didn't do so great on one issue, like getting clinics in. I had to go and talk to 30 different clinics to get a couple to participate. That's actually fine, but I think being transparent about that will really help address the replication crisis. And I think a big part of that is maybe it's not an actual failure to replicate, but we're not clear enough about transparenting, like what is the setting, who is it that's participating in things, and it may just be that you have a great intervention effect, but it doesn't work in some settings. So with that, I'm going to turn it back to Amy, and let's have a good conversation, hear your thoughts and feedback.
Well, I think you all can't be seen in your applauding, but I'm going to lead us all in applauding our presenters and our discussant, Russ. So thank you all so much, Doctors Birru, Cockroft, and Glasgow, for that excellent presentation and for leaving some time for discussion. We have some excellent questions in the chat. I think we'd like to start with one from Katie Trinkley about could this be used for grant proposals? Could you see a way that this might be used in that vein? I don't know, either Ermyas or Josh, if either of you have thought about that as we've been developing this.
Yeah, I mean, if it's about logic prepare, I think we had this discussion within our team as well. We don't want to suggest something that would be another burden for you as part of requirement, but this is kind of to help you as you plan your grant proposal to think about, to anticipate where could I have possible drop-offs using like their EAM cascade or some of these tools. So I think would be I see benefit in using this as part of your grant proposal, thought process. But I am one of the against to make it a required. But at least it helps you to think about in the early stage as part of your planning tool. Josh, not sure you want to chime in here.
No, I would agree. I'd echo again. I think it's the intention is for it to be helpful as a kind of a critical reflection tool, as opposed to necessarily. I'm not sure any of us are champing at the bit for this to become a requirement by a NIH funder that somebody has to fill this out as part of a proposal. I think that would not necessarily be the intention where we'd intend for this to go. So not necessarily a requirement, but again, intending to be useful just in kind of the early planning phases or during implementation of a study.
Wonderful. And we had two questions from Stephen Bartels. Stephen, if you do want to also be able to come off mute, you can raise your hand. But I was going to pose them, Josh, for you to take a shot at the questions initially. If you see them in the chat, I'll restate that a compliment first, very impressive, comprehensive tool, terrific work. Then question one was like many predictive tools, the final simulation relies heavily on assumptions embedded in the estimates at each stage. Where do these come from and how can they be validated and accurate? We'll take that question first, and there's a second as well.
Yeah, no, I think that's a fantastic point. Really thinking, I think even in putting together with the early user testing, we did like an early think aloud session as part of the fellowship, and really thinking about at each one of those levels, how are we coming up with those numbers? And I think there are certain things I think are very straightforward, right? You know, the easiest number, even though it's the one that maybe most people will be less likely to use, would be going and looking at like a census population, for example, for the US or a given state. I think it is important to address. I think in guidance around some of those, I think some of the numbers are more directly tied to things that are pre-existing within kind of how we think about designing trials. So thinking about with patient population, like we're always going to have probably a power sample size, right, that we're thinking about. So I think that number in and of itself in the planning stage is a little bit more straightforward. But I agree that some of the other levels and kind of thinking about that and kind of working through that are a little bit more nebulous. And I think something where we would hope to be able to provide some additional guidance after some additional user testing about how to work through some of those and make sure that the numbers that are being used are useful and somewhat reliable, and kind of working through that. So I'd say it's still very much a work in process, but do want to acknowledge, I think that is I appreciate your sharing and sharing about that point.
And I see
Well,
Russ, you raised your hand. Maybe we can let Russ tag on. Is that okay?
I did. I just want to do that. First of all, Steve, thanks for the great question. In addition to what Josh said, which I certainly agree with, there is, I think, in terms of the notion, if you will, of simulation or guessing what we can do, like, for example, participation or engagement that people have there. I think look at a few sources. One of them, again, I think if we can go back and look at the literature, and maybe these days we can use AI, to help us go back and see what quickly summarize what the literature is. That helps. I think certainly those of us that have been around for a while, like you and me, Steve, have our own work to fall back on in a particular area. Think about where things have gone wrong. And then finally, I think that it may be useful to do, and like economists do, to do a type of sensitivity analysis. And, say, well, I don't know, it probably isn't going to be exactly 70% that I think will get there for engagement, but it probably is going to be, I'd be totally shocked if it wasn't between 60 and 80% or something like that, and look at the impact both ways.
Wonderful. And yes, Steve, please do let us know if you wanted to unmute. You can raise your hand so that the group can unmute you. But I think that the second question from Steve also is coming up in some of the other comments in the chat, which is really about the distinction between using the tool for planning and using the tool in actual real time when a trial is happening. There were comments about, I think I could see this being used in a trial I'm part of right now, comments on using it in multi-component studies, comments about using it and then triggering action of, oh, we're seeing a dropout in this certain group. Maybe we should try to interview and learn a little bit more about what's happening there. Just wondering if either of you, Ermias or Josh, would like to reflect on how you've seen those potentials for using it during implementation as compared to the planning phase.
So I can share, I mean, I think as a group, we originally tried to have three versions of the tool, one that would be pre, one that would be post, and one that would be during. So again, kind of trying to think about tracking implementation. Ultimately, for simplicity's sake, for right now, we're focused on kind of the before and after, but I would say conceptually, it is definitely something that I think there are potential for applications, even if we're not necessarily there yet with this version. But would be happy to, share kind of if Amy, Russ, or Ermias had other thoughts there.
Yeah, I
Ermyas?
think, with the other tools uh, that we shared as well, I think with the re-aim cascade, I think that one could be applied multiple times. We can always, that cascade we showed is always an opportunity as we go through the implementation, we could look at some of these, the drop-offs, and then always go back to make some adaptations with the re-aim cascade tool. And I think with the expanded consort as well, trying to understand, okay, why do we have drop-offs? And is this something not only just for us to say, okay, these are barriers, this is why they're not understanding, but are there strategies that throughout that we can think about, as using the tool in multiple time points, that we can actually come up with strategy. For example, if participants are having some type of, access issue, physical access issue, can we come up with some strategy to enhance that retention for the participants? So with the logic prepare, I think, as Josh said, it could be again used during implementation, not just planning and reporting. But if you have the capacity and once you get used to, the use of the tool, I think you might be able to think about, okay, if I have this drop off here in the grand scheme of things that I thought about, can I actually see how this impacts at the end? So there's always that opportunity to think about even during implementation, not just planning and after the implementation. I think Russ wanted to say something, I
Yeah.
guess.
One quick thought, but let me first see if Amy wants to announce it. And then I see, as usual, Dr. Estabrooks has a stumper question. So hopefully we can get into that if we go give a quick response here. Amy, do you want to enter in?
I do. Of course, I want to enter in. And I'm wondering to address directly Paul's question. Josh, could you go back to our slide with the QR code? Because we are kind of coming towards the end as well. And want to give people a chance if you're interested in being able to be sort of on the ground floor of helping us take this type of work forward. You can scan this QR code. As was put in the chat, we're going to post this recording, and I believe we will also post the slides so that this doesn't have to just be a one-time to use this. But to help expand the reach of these tools, we're doing this webinar. We will post on the website, and we will work with you all to help us be additional end users and help us consider how to make these better and how to share them out with folks. Reflect on a comment that Rose had made earlier on in the chat about appreciating that really the theme here is being able to think critically about our work and who we're reaching and who we're not, really taking the principles of representativeness and inclusion to heart in how we would design and carry out studies. And as was mentioned by the presenters, really being thoughtful about ways to prevent the loss of impact over time and the loss of people in our studies. So just wanted to reflect on that being really the theme. And also, as was really nicely articulated, showing these tools range from more simple to think about things like an Arium cascade pretty simply and more generally with more of a one-pager. And then when things are a larger trial or aiming to be particularly large and generalizable, that logic prepare tool we're trying to continue to refine more towards that purpose to drill down. So those were the comments I wanted to add. And Russ, I think you did want to have a last word before we close. Our time is growing short.
Yeah. So last word, and will be at least a 3-hour discussion, I think. But embedded in Steve's question or others, I think this notion during to maybe guide adaptations during implementation is still a bit of a open debate, I think, or people with different feelings. That some people think that if you make an adaptation during the intervention, that's poor fidelity that's going on there and will mess it up. I think some of us have a different take in terms of the definition of fidelity, but I think there are some ways that are experimentally very sound. Amy and Steve mentioned Royo designs there for rollout implementation designs. There are smart designs where when things aren't going well for some settings or people, you experimentally do something else. Myself, I think we far underutilize things like time series going there, which isn't quite as tight as a total randomized design, but to look at this critical issue of replication over time for the adaptations that are being made during implementation.
Excellent. Thank you for closing us out with that last word, Russ. So just again, a thanks to our presenters, to Dr. Birru, Dr. Cockcroft, our discussant, Dr. Glasgow, to all of you for joining and giving us an excellent discussion. We will share, we heard a request for the link. Oh, good. Mickey, that's the link that the QR code goes to, just to specify, is that right?
Yes.
Yes, okay, perfect. So addressed just in time. Fantastic, Mickey. Submit the hardened question for us. And we'll look to share out these slides and the link, post them on the website, and share with others as well. Really appreciate everyone's time today. Thank you so much.
Take care.
Look for more reading webinars coming soon. We'll keep you on the list.
That's right. Take care, all.
Thanks, everyone. Great work. Thank you. Appreciate it.
Thank you. I was just taking a quick look at the chat before we sign off.
Sure. Yeah. If you want to save it, Josh, we probably could.
Perfect. I just saved it.
Did you just save it? Okay,
Yeah.
perfect.
Perfect. All right. Thanks, all.
Thank you,
Thanks,
guys.
everyone. Bye.